Hi, I'm Matthew Brain. I'm a student at Monash. The date today is the 12th of May 2013 and I'm here to showcase my clinical and communication skills when it comes to taking the patient's radial pulse, the respiratory rate, the palpative and auscultative blood pressure, the chest auscultations just posterior, and the Glasgow Coma Scale score. And this is my patient today, 78-year-old Mr. Jones. Please make him welcome, everyone. Now, have you had your pulse taken before?
Yes, I have.
And is it okay if I do it?
That's fine.
Got no problems?
Yeah.
Right. Now what you're looking for here is the radial artery, which is located right here. You feel for the pulse, apply adequate pressure. Once you've got it, then you count the pulse. After 30 seconds, you times it by 2, you get the reading. That'll be the heart rate. Then you do, the patient won't know this, but you record their respiratory rate after that. Because often if you tell them that, do you mind if I take your respiratory rate, they may alter their results as they are conscious of it, and this can this won't give you an accurate reading, basically. And are you stressed at all today, not feeling anxious? You find this can also affect the pulse and respiratory rate. Okay, thank you, Mr. Jones. Next thing is taking palpitative blood pressure. Now, have you had your blood pressure taken before?
Yeah, I have, yep.
Yeah, excellent. And once again, are you comfortable in this position?
Yeah.
Have to make sure the patient's sitting upright at all times. You line up the arrow with the brachial artery, should be about 1 inch above the crease in the elbow. Now you may feel a slight squeeze here, and that's fine. Yep. Feel the pulse of the brachial artery. Once you've done that, once you've got a good pulse, you apply pressure. You feel a squeeze now, Mr. Jones?
Yep.
When you stop feeling the pulse, you release slowly in bits of 5 until you feel the pulse again. That's a systolic blood pressure, and that's all the palpitative technique can measure. Whereas the auscultative measure with the stethoscope can also measure the diastolic reading. And this is basically where you're listening in. And you won't hear anything initially, not until you start pumping. Squeeze again. When you hear the sound, you go one over, and then you slowly release. When you hear the sounds again, that's a systolic reading. The sounds will slowly alter as you're going down. And when you can stop hearing sounds altogether, that's the diastolic reading at that point. Very good patient, Mr. Jones.
Thank you.
Next is the posterior chest auscultations. Have you ever had your breathing monitored? Anyone heard it before?
Yeah.
You've got no problem with that?
No, it's fine.
Would you mind facing your back towards me?
Yeah.
Thank you, excellent work. And lifting up your shirt, yeah, thank you. Would you mind coughing from your chest? Yeah, thank you. This removes any unwanted sputum which can give you an inaccurate reading. Now just take normal breaths for me, Mr. Jones. What we're listening for right now is any abnormal breathing sounds. Does the left equal the right? As you're going down, does it alter? Is there any difference in every side that you're breathing from? And are there any weird noises that shouldn't be there unnaturally? You can put your shirt back on now. Thank you, Mr. Jones. Just like crackling or wheezing. All the way through this, I'm supposed to be practicing non-verbal techniques such as proxemics. I'm getting in a personal zone, and that means I have to adjust my tone, which is make it less intimidating, less aggressive, makes the patient feel more comfortable. Also just a simple touch when I'm taking his pulse, when I'm doing chest auscultations, it's comforting for him. Just getting eye level, getting good eye contact with the patient, it makes them feel like you're giving them your full attention. They feel like they're more comfortable that way. Lastly, I'm going to do the Glasgow Coma Scale score on Mr. Jones. And as soon as I walked in the room, I noticed, and throughout the tests, I've noticed that his eyes have been following me around the room. He's been completely aware of that. I haven't needed to ask him to open his eyes to get a response or anything like that. So therefore, he scores a 4 for eyes, which is the top mark. Next is verbal communication, which is, I'm just going to ask you a few questions now, Mr. Jones, if that's okay. What day is it today?
Today is Sunday.
And what month is it?
May.
What year?
2013.
And where are you right now?
I'm at the surgery. Just
Okay,
a checkup.
Just for a checkup. And what season is it?
Autumn.
Okay, excellent. So what I can gather from that is that he's completely aware and orientated. He knows exactly the time and place. He's taken in all of his surroundings. He's not disorientated in any way. Which means he scores a 5 for that, which is the top mark once again. Lastly, we do a motor response, which is just, this is just a basic test. Mr. Jones, would you mind reaching up and squeezing my fingers? Thank you. Yep, excellent. The concluding that he was competent enough to just reach up and respond to what I was saying and squeeze my fingers adequately without any discomfort or any pain or any difficulty, I can give him a 6, which is the top mark for that as well. And overall he gets a 15 in the Glasgow Coma Scale score, which means he's completely conscious and completely aware of what's going on. Doesn't have any concerns in that regard at the moment. Once again, my non-verbal communication techniques. I've been a very attentive listener. I know, Mr. Jones, you haven't a lot to say today.
No.
But just getting eye contact with the patient, not too much to make it uncomfortable, but still just establishing a rapport with the patient. I hope you feel comfortable today, Mr. Jones.
Yeah, good, thank you.
And just general touch, just adjusting your tone when you're getting in his personal space, such as when I was doing the blood pressure or the stethoscope reading on the chest auscultations. Thank you.